Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. As I look outside the window, there's not a cloud in the sky. It's just a bright blue visage. And it's wonderful for us this afternoon to have Dr. Amy Wise, and she's going to be speaking about RSV, the resolving, evolving landscape of vaccination in pregnancy. Now, I've just been chatting to Amy, and she's a woman with huge and varied Catholic interests. She speaks about a great range of topics. She's doing research in Group B strep, vaccination in pregnancy. She works with RSV. She works with Prem Labour. She's head of department of Rahima Musa. She's on the SASOC committee, and she's been there for many years. And she's on the FIGO committee for infectious diseases. So virtually there's nothing in obstetrics or gynecology. She's doing AI in colposcopy for the Koreans. There's nothing in AI or in gynecology that she has not done or will not be doing. So it gives us wonderful, wonderful pleasure to have you here this afternoon. Remember that next week, Thursday, is not Good Friday. Next Thursday is not Good Friday. Next Thursday is Maundy Thursday, and that's just before Easter. That means that we will not be having a talk next weekend because of the Easter break. So, and a special thank you to Professor Steve Jeffrey, who's our co-host and sponsor, and also, of course, Chris, who is the technician setting everything up and keeping everything running smoothly. So without further waste of time, Dr. Amy Wise, RSV, the evolving landscape. Hello,
Hi.
Amy.
Yep. Hi. Good evening, everyone. And really, thank you. So it's definitely not a beautiful day in Joburg. It is grey and it was bucketing down just now. So we're not quite as lucky as all of you. But really, thanks again for inviting me. And I really appreciate the invite. And I think what's been interesting, I've done a talk for you guys a couple of times, and is how much it really has changed the whole vaccination and pregnancy landscape over the last sort of 5, 6 years. You sort of go look at what you presented before and you realize how much has changed. And I think it's a really interesting and exciting field to be in. So let's hope. Yeah, there we go. So I really do like this particular slide because it comes from Martin Noon's textbook, and what we're looking at here really is just that evolution of vaccine development over the last sort of 120 years and the various outbreaks that have occurred along the time. And obviously those outbreaks as we go sort of spur on development. And you can see there after the big influenza pandemic in 1918, around the time of the war, just after that out came a whole bunch of different vaccines, the diphtheria toxoid, tetanus toxoid, the influenza whole cell later in 1936. And various combinations went on. And so we went on through the last century. The oral polio vaccine of particular interest in my family, since my mother was caught out by it, unfortunately, in the 1940s. And so we went through the meningococcals, and then unfortunately in 2020, we all know about COVID-19, and that really accelerated vaccine development. And people, if everyone remembers, were quite nervous around the time. But, it was built on a lot of vaccine work that had come from before in recombinant genes and things. And this is now culminated most recently in RSV being with the FDA and approved in August 2023. So, in fact, the textbook sort of ended around 2020, and so I tacked in there. The RSV now is no longer in development, but we now are lucky enough to have it. So, I come definitely from a government background, and so there's a large public health slant to what I'm looking at. And we're looking for evidence-based interventions for reducing mortality. We really do need to have the research behind us so that we ensure that we try to reach as many people as possible and bring down our huge burden of disease, and aiming for those 2030 SDG goals to try and improve maternal and child health. So around the perinatal deaths, you can see I've rung their maternal vaccinations, and specifically within the new integrated care guidelines for maternal health, they've highlighted tetanus toxoid, hepatitis B, and flu vaccine. So the hepatitis B is another whole discussion, which is currently happening. Maybe we must look at that next time. So why is it so important with the deaths averted due to vaccination? So this particular graph shows you our biggest win has been with measles, 93.7 million deaths averted due to the use of the measles vaccine. After that is tetanus, 27.9, and then pertussis at 13.2 million. So it'll be interesting.
Amy,
Yes,
can I just ask a question? Something's come up here
absolutely.
on my. It says here, if measles is such a wonderful way of averting deaths, isn't
Mm.
this the thing that's been stopped in the United States of America, the basis of the advice of what's the chap's name in charge of Trump's Department of Health, Kennedy?
Kennedy,
Kennedy.
yeah,
Yeah.
Kennedy.
Have they stopped
Yeah,
the vaccination? Or
no, so there, you're right. I mean, if you go into the press, though, I think that's why you've had such an exodus of people from the NICD and from the various other health organizations in the States, because the science really isn't being listened to. And it's unfortunate because there have been outbreaks in a number of states. I think Texas in particular has been hit very, very hard.
yeah,
And that sort of reliance, I think people got quite comfortable because herd immunity, especially in places like the States, had become so good, that idea that actually we were all protected. But it doesn't take long for herd immunity to wane. And that's exactly what we're seeing now. We're now seeing this resurgence, and people are paying the price. And now we're having to work against this whole sort of anti-vaccination stance and trying to get all the programs up and running again. So yeah, it really is a bit of a tragedy and really unnecessary. So it'll be interesting to see how the politicians play it out. I think politicians largely should stay out of health.
has
But
this spilled over into our country? This anti-vaccination hype and
Um, there's a lot of we certainly when we attend all these conferences and things and we have discussions and working groups, we do bring it up a lot. And there has been some sort of anti-vaccination stance, but I think our bigger issues here are more just the reach. We saw a
uh,
big dip, especially in like our second, so like the first vaccination at 6 weeks was being given quite well to children, but it's the follow-up vaccinations thereafter, accessing the healthcare facilities, making sure that the vaccines are, readily available, not just in clinic hours. So those are, I think, the barriers that we struggle a little bit more with, getting it to everyone. And government tends to work a little bit better in terms of programmatically getting to all people, whereas in your private sector, it's not as routine, especially maternal vaccination, making sure that patients access it when they actually come for care. If you our clinics are supposed to be sort of one-stop shop. You'll get all your care in one place. Whereas if a patient attends their obstetrician for a 6-week checkup, they've got to go make a separate checkup for their pediatrician. So as far as possible, we need to create hubs where sort of a wide range of services are either having a GP working in a private hospital who provides these linkages between maternal and child health and sort of a family healthcare approach to ensure that they don't slip through the cracks.
yeah,
So
so it's not as more logistical than conspiracy theoretical.
I that's certainly what I understand. I mean, obviously there will be people who feel that it's not, not for them, and if they eat healthily and various things, it's going to be enough. But I think logistical and then the money side, because truly the money side of it then also gets very expensive depending on how you're accessing your care in private and what your medical aid setup is like. I mean, just today someone phoned to say, could I help with a patient because suddenly it's been found that she's actually on an insurance thing and not on medical aid, and I'm sure that story is familiar to you,
Yep,
and now
yep.
I'm not going to cover the baby. And so there's this mad dash at 37 weeks pregnant to get her into a government hospital somewhere. Because of
So
course
do
the
you have just on
complications.
another topic, another tack? A person said, do you have to have consent prior to Tdap, for example? And do you have Tdap as we do here at Curtis Care Hospital? Do you have Tdap vaccination in the state sector?
Yes,
Route.
it is throughout the state sector. So it's replaced the use of tetanus toxoid.
Okay.
And obviously it makes it easier because it's a single dose as opposed to trying to get through 3 doses.
Yeah.
But there was a nice paper produced by Claire Cutland where they did show that the first dose of tetanus had reached more than 95% of women received their dose of tetanus. So we can then sort of extrapolate that the Tdap will be very well taken up, and we will get very, very good coverage with Tdap. And that's why I do think that it does work very well, getting it out there. But now the next issue really with the RSV is the cost.
And that's it's. I mean, it's a sort of a phantom leap upwards for the cost of a Tdap versus, I mean, RSV versus Tdap. Do you see? You're
Hmm.
going to be talking about it, so we better just ask the people to stop questioning, and you get on with the talk. Thanks.
No, it's fine. So the importance of vaccine, I really appreciate all the questions. So vaccination programs have traditionally always targeted children, and so therefore we've seen that's where most of the benefit has been in terms of a decrease in disability and death. Whereas then we see 42,000 adults versus 300 children die each year from vaccine preventable illnesses in the US. And more than 50% of cases of significant vaccine preventable illnesses reported to the CDC back in 2004, it is an older statistic, occurred in people over the age of 15 years. Maternal immunization caused a 92% global decline in neonatal tetanus deaths through tetanus toxoid vaccines. So we can see that really then that targeting our adult population, we will have a really good outcome. So I went to look in the popular press, as you were saying, and most of this actually came out of the States. You can see their New York Times. I think one of them was also the Today, which is also the American, talking about the RSV surging in the States. And obviously, it was also with measles in a number of the articles. But there is a lot of awareness out there about respiratory syncytial virus and its impact. So it does have a significant economic impact, costs for admission, oxygen, ICU care, and caregiver absenteeism from work. So there's an overall impact. And so our prevention is our priority. Predictable seasonality supports a planned population level immunization strategies if one goes the seasonal route. And for every RSV associated acute low respiratory infection in hospital death, there are approximately 3 deaths attributable to RSV in the community. And these I help on a study called the CHAMP study, which is looking at all under 5 deaths and stillbirths in the Soweto district. And the deaths that we never see, these little children coming in and who sort of go straight to the mortuary and who are then assessed for what are their causes of death. And certainly there's a large impact of viral illnesses which catch these small children out in the community. So vaccination in pregnancy works through 2 different ways. We've got active immunization and passive immunization. So either directly we immunize mom, and so then she at least is not affected, and she'll produce the IgA, IgM, and IgG, and the IgG is what we want to cross it to the baby. The IgA and M and G will also be given to baby through the breast milk. And so this also is important that even if we catch a patient right late in her pregnancy, certainly for Tdap, still give the vaccination because there will still be a benefit in that mom shouldn't then get ill with something like pertussis. So she's less likely to be infectious for her child. And also she will still hopefully be breastfeeding and she will then protect her baby passively through the breast milk. So the maternal IgG function in infant immune protection, you can see there, it slowly starts to build up throughout the pregnancy, and that IgG transfer starts from 13 weeks gestation. And in the 3rd trimester, the expression of the FcRn increases, and subsequently the transfer rate of maternal antibody improves with the highest amount of IgG transferred during the last 4 weeks before birth. So it is a cumulative process, and the infant antibody titers rise approximately 2 weeks after maternal vaccination. So we would like to get that window in, which is why you'll see the guidelines say up to 36 weeks with this idea that mum will deliver it sort of 38 plus. But I would still advise that if she arrives late or she only able to access care late, that we still give that vaccination.
Amy,
Yes,
one more question. Um,
sure.
so there's 2 types of immunity conferred on the babies. One is prior to delivery by placental transfer, and others in breastfeeding. Which is more
Yeah.
important?
More important, I think it comes with what it comes with. I'd say that your placental is probably the most important in terms of the volume of immunoglobulin that you're getting, but I'd have to check the exact amounts. But I think it's all your other benefits of breastfeeding as well, which is a cumulative effect then. I don't think you can look at breastfeeding as just being about antibody transfer. The
Right.
nutrition is so very important. If we've got a malnourished baby, it's far more likely to get ill and to catch an infection than if it's been breastfed. And so, as far as possible, supporting moms in their breastfeeding, and that discussion needs to start during pregnancy so that they feel empowered enough to be able to breastfeed.
Thank you.
Sure. So the period of vulnerability for infant infectious diseases. So I've highlighted the two that we currently have available in state there, the Tdap and the influenza virus, well, the influenza vaccine. And you can see that early part, just after delivery, is when babies are most vulnerable. They haven't yet formed their own antibodies, and the EPI program only starts around 6 weeks. So it takes a bit of time before they're going to be given vaccinations themselves. So we have that window of vulnerability in the first couple of months, and that is really why between the breastfeeding and maternal vaccination, we want to emphasize those two strategies. So in 2024, our national guidelines were then published, and we've recommended there the Tdap, influenza, and COVID-19 when it's available. If indicated, it would be the polio, the Hep B, and rabies. And what was not yet then included was the RSV, because it had only just very recently been what's it um,
Released.
released. Thanks the
Released.
word. Thank you for the word.
Uh,
Right.
and Amy, just to
Yeah.
get back to rabies,
Mm,
we had this talk a while ago. I mean, about rabies.
yeah.
How important is it to vaccinate people against rabies? I know some women think their husbands are mad dogs, but I think it's not that universally available. Doesn't it have to
No,
come?
it's only if you've had contact.
Okay,
So it's really important that you're aware of animals behaving strangely and everything. And
okay.
my daughter rolls her eyes at me since you're down in Cape Town. There is a massive problem with rabies in the seal population at the moment.
Seal.
Yeah, in the seals.
Oh,
So
wow.
yeah, so there've been a number of seals which have been behaving strangely, and dead seals. So please, it's really important if you see animals like that which are dead on a beach and that kind of thing, do not touch a dead seal or anything. Please inform who's at the aquarium down there and stuff so that they can come and deal with the bodies. But it really is a very big problem. So I've told her, like, slow down on Saunders Beach. Um,
I can concur with Amy. I've got a friend who had a friend who was bitten by a seal, and they were very worried about rabies. And it's a bigger problem than we actually mentioned. And thanks for bringing that up.
Yeah, so please, it's that, and I'll mention maybe diphtheria just now as well. I think I mentioned it last year as well. Diphtheria is still busy circulating, so please be very careful of diphtheria, which is why the Tdap then actually is very useful. So the recommended timing, so influenza is at any gestation of pregnancy, really there because our focus is on mom. We prefer to get it early in the season. We know that we only ever get about 10% coverage in the state sector. There's just not enough vaccine produced. So please advise your pregnant patients, especially those who are going to be in the third trimester through the winter months, to preferably get their vaccine done. Then Tdap is from around 26 weeks, but really from 20 weeks onwards, it is fine to give them the vaccine, especially patients who you're anticipating might land up with a premature delivery. You'd like to make sure they've got it, and that is to be repeated in every pregnancy. RSV is from 28 to 36 weeks. I will mention it later, but you'll see also that they sometimes say 32 to 36 weeks, and that was because of the signal of is there prematurity. And is that an issue? That was because of the study was run, and part of the research was done in South Africa, and it was done across the time of the COVID-19 pandemic. And so there was this increase in premature babies at the time. So it really wasn't thought to be done due to the vaccine, but that was why initially it was released as at 32 to 36 weeks. But the package inserts now are from 28 to 36 weeks. At the moment, it's once in one pregnancy. There isn't data yet to say how often it needs to be done, if it needs to be repeated in every pregnancy. And in some places like the US, they are doing it seasonally, but other areas in the world, like Chile, I think it's Chile, they are doing it as around the year vaccine because although obviously you have your peaks, RSV is detected throughout the year. COVID-19 again is really more for mom. It's at any gestation, and it's only if there's going to be another surge. There is no vaccine available at the moment, so I think unless we land up in another, let's God forbid, wave, we will not be giving it to anyone. But primary course and then boosters when they're available.
Amy,
Yeah,
just to go back to that previous slide that you did there,
this
that's
one.
right. Do we only give it to the mother? I've heard it said that you should have an RSV vaccination in every pregnancy. And secondly, is there any point in giving it to caregivers and people around the mother in addition? Given that it's a very expensive, how much does it cost?
It's about, I think it's about 3.5. If I
Yep.
think I've got a thing, yeah, it's about 3,500. So the thing is that this is the data that I was given a little about 2 months ago, I think it was,
Right.
and I hadn't yet been told that we're going to be doing it when we were having our various meetings. But I think that information, I mean, if we've started in 2023, the women who possibly are in the trials will be probably starting to have their second pregnancies now. And so that data, I suspect, will start to come through in the next year or two, saying, what should we do with the second? What is your immunity like? How does the immunity wane? And is it enough to protect the next pregnancy, or do you need a booster for the next baby? Or should you maybe rather be looking at using the monoclonal antibody in the next baby and not reboosting the mom? So I think those are the sort of questions, and a lot of it will come to do with money and availability that we're going to need to answer over the next sort of a couple of years. So I do mention some of that just now. So just pregnant women with RSV themselves, generally a cough, headache, rhinorrhea, and a sore throat, but often with no fever, and it is not usually associated with adverse pregnancy outcomes themselves. With the RSV infection in mum, it was associated with an infection in half of their infants. So definitely making sure mum gets vaccine will prevent then that transmission from mom to the baby. 29.8% of mums investigated within a week of their infants having RSV also tested positive, and that's obviously with that very close relationship that they're having at that time. So hand washing and making sure that people follow sort of universal precautions is really important when they are ill. The common viral illnesses in pregnancy, there the influenza I've mentioned, the RSV, and again COVID at the very bottom, and the RSV, at least in influenza, we have then got those vaccines for. Now, I've got two slides. This one is from Europe, just about the same week, 9 to 15th of March. You can see RSV is in 11% of the tests that they are running. So quite high rates of it busy circulating through Europe. And if we have a look here, this is same week just about in South Africa, and the RSV is just starting to reach the low threshold. And if it is above that, I don't know why they made those two blues so similar, but anyway, you can see there's sort of a slightly paler blue at the bottom. So if it is the same when they release the data, probably later this week, and we're into that low threshold, then they will officially say that the RSV season has begun. But even though it's pretty low in those parts of the year, the summer months, there is still enough circulating to warrant giving the RSV vaccine. So RSV itself, I'm not even going to go there, Paramyxoviridae family, right, single-stranded RNA virus with 10 genes encoding 11 proteins. And protein F and G are the two important ones, especially the F when it comes to vaccinations. And they form the virus attachment and syncytia formation on the target host cells and cause all the problems. So RSV pre-F protein, it's got 6 dominant antigenic sites, and these sites are key targets for host neutralizing antibodies. And the sites O and V are the major drivers of the antibody response and the potent neutralizing activity. The F protein is genetically highly conserved, and continued genomic surveillance is critical to monitor the emergence and prevalence of potential resistance mutations that may affect the therapeutic efficacy of monoclonal antibodies or vaccine. There's a Lancet article published not so long ago to which a number of prominent South Africans have Heather Zar down in the Cape, Prof. Mardi up here at Wits, where we are giving in our own data and busy looking at the genetics and taking part of the genomic surveillance so that they can watch to see that if things start to change, our vaccines take keep up with it. So the RSV burden, it is the leading cause of infant LRTIs. It drives the ED visits, hospitalizations, and ICU use in infants under a year. And the highest risk is in that first 6 months. And there's an immature immunity and low reserve drive severe disease. And one death was attributable to RSV in every 50 deaths of children under 60 months, and 1 in every 28 deaths in children from a month to 6 months is attributable to RSV. We do have seasonal surges, as I showed in that slide just now, and in that time it strains the public and private systems. We have a higher risk in preterm babies and the comorbid infants. Certainly at Rahima, our wards get filled, the pediatric wards during the winter months, and given that we deliver around about 10 to 15% of our babies are SGA or IUGR babies, it really does cause a massive problem in our hospital. The clinical consequences of severe RSV disease in infancy, there's immediate respiratory morbidity leading to bronchiolitis and pneumonia, often requiring hospitalization, oxygen, fluid, and sometimes ventilation. We have, I think, 8 ventilators on our side, so 10 ventilators. It's really not enough for a population that we serve. And the admissions are distressing and carry the risks such as secondary infections and a prolonged recovery. The long-term sequelae. So early severe RSV is linked to recurrent wheeze and higher childhood asthma risk via airway inflammation, immune modulation, and structural change. And reducing severe RSV in infancy will decrease acute hospitalizations and will support better long-term respiratory health. At the moment, with current RSV management, there is no effective antivirals for infants, so it's supportive care alleviating the symptoms without altering the disease course. The supportive care can be life-saving, yet it is still limited, and it does not necessarily prevent that progression or reduce the long-term respiratory risks in all cases. It strains the system and access gaps. Hospital admissions surge during those seasons, and the advanced support may be limited in resource-constrained settings. And so really prevention is the main lever that we have to try and reduce the burden of disease. So shifting it upstream reduces the hospitalizations and drives better system efficacy and outcomes. So the Matisse trial is the one that South Africa also took part in. There was the phase 3 randomized double-blind study to test the RSV pre-F vaccine safety and efficacy in pregnancy. We had over 7,000 pregnant participants from 18 countries, diverse ethnicities and income groups, and they were enrolled for broad representation. So they received a single vaccine or placebo dose between 24 and 36 weeks, and those follow up through delivery and infant monitoring up to 24 months. The preterm birth rate was 5.7% in the pre-F vaccination versus 4.7% in the placebo. So the relative risk was without statistical significance, but the absolute number difference was where the issue then came in, and that is where they are redoing some of those in 4 countries just to have a look at that preterm delivery risk. The adverse outcomes, there was no significant increase in low birth weight, neonatal hospitalization or mortality with the vaccination, and overall the vaccine was found to be safe.
Sorry, Amy.
Sure.
Could you just go back one more? Another question. How is it administered? Is it a snuff, or is it an injection, or how is it given? What this vaccination?
It's an injection into the arm.
Injection into the arm. And
Yeah.
can you explain why, if you just go to the next slide, why the relative risk is only 1.2? Because somebody here says unless a relative risk is 2, they don't believe that it's of any use. Can you explain that?
This is a relative risk of getting a preterm labor. So the issue was, is it causing preterm labor as a safety issue? That is what people were worried about. And the signal mainly came, like I say, most of the data or the preterm babies came from South Africa. So it's not that it's, is it protective? This is not talking about vaccine efficacy. This is just talking about people who did or did not have a baby who was born preterm. And
Okay.
so it's not about the efficacy of it.
Okay, thank you.
Yeah. So South Africa exhibited the most pronounced difference with a relative risk of 2.06 for preterm birth.
Oh,
So
all
when
right.
they broke it down, when they broke it down into all the specific countries. So that's why we've got this multi-country study happening in 4 African countries to evaluate again with the risk of preterm birth and low birth weight as key outcomes.
So it's important that we use it because also South Africa's got one of the highest incidences of strep B in the world. Is that correct?
Group B strep, I'm not sure
Yep.
about the highest incidence. Maybe you know that incidence
Well,
more
that's
than
what
we
Phil
do.
Steer told us
Hmm.
when he
When he was
gave the
down.
talk. Yeah.
Yeah. So, look, I think in general we want to try and vaccinate as much as we possibly can. But I think the group B strep obviously is a slightly different thing. So, just to run through the different vaccines. So, Abrisvo, which is the Pfizer product, this has got the stabilized pre-F antigens for both RSV A and B. It's passive immunization through the transplacental transfer. And then the efficacy is 80% against severe RSV associated infections up to 90 days, so 3 months. And the efficacy is 70% against hospitalizations in those younger than 6 months. So, really, the biggest benefit there is in those first 3 months. And the effectiveness for preventing infant hospitalization was 72 versus 58% for infants whose mothers were vaccinated more than 14 days before delivery versus at any time. So that obviously must have included some patients who were vaccinated just before they delivered. And that then goes back to where I spoke about the transport of the IgG, and that the baby really does best if you can get that vaccine in 2 weeks, at least 2 weeks before the mum delivers. So really very, very high effectiveness in preventing hospitalization. There was no increase in any congenital anomalies. There was no fetal deaths linked to the vaccine. And then there was just, as I mentioned, that imbalance in preterm births. And then the newest one, which has just been released, and maybe some people also joined some of their launches, was the monoclonal antibodies. So this is the very first one, which was out in 1998, was palivizumab. The problem with this one is that it was a monthly dose, and so that really limited its use and also made it very, very expensive. So monthly dosing, and it was recommended for high-risk infants less than 12 months, and rather than all the infants, because it was just, out of reach, I think, for most people. And then what happened is they've extended the half-life now for monoclonal antibodies as opposed to this monthly thing through YTE mutations of the FC component of IgG. And this resulted in 2 new single-dose long-acting monoclonal antibodies. And this is what was just launched earlier this year. So there's Beyfortus, which is an AstraZeneca/Sanofi product. A different target site, it's a single dose, and then up to 150 days after administration was about 77% effective in preventing the hospitalizations in infants. The efficacy is higher in infants less than 3 months, 89.6% during the RSV season. And the vaccine efficacy against all-cause lower respiratory tract infection was 42.8%. So the PICU admissions also declined, so basically halved when you compared the pre and the post nirsevimab period. This was, I think it was in Chile or France, maybe France, and it had a favorable safety profile with no serious adverse events, a little bit of pain, a little bit of a rash, but that was all that really happened. Similar to that, it was a Merck product, slightly different target site, but very good outcomes. So up to 150 days, 84% effective in preventing RSV hospitalization in infants, and a vaccine efficacy of 49.0. So the favorable safety profile again, and no serious adverse events. The number needed to immunize to prevent one hospitalization was 35. So I suppose this is now where now maths is going to come in and how much it's going to cost. 35 immunizations at a cost of around 6,500 now with this to prevent one hospitalization. So maternal vaccine and the passive immunization. So we've now really got 2 different things we can use. Either we can vaccinate mom or we can passively immunize by giving the baby the antibody. So there are no studies yet to compare the interventions. There was a French national population-based cohort study, and they found that the passive immunization with nirsevimab has a lower risk of hospitalization for RSV, a lower risk of PICU admission and then those requiring ventilatory support and those requiring oxygen therapy. So this is about as good as it gets in terms of head-to-head comparison, that the monoclonal antibody was better than the maternal immunization. But the cost is significantly more. So we got about 3,400 in the private sector for Abrisvo and 6,400 for nirsevimab. should one maybe then just target your sick babies? But if one looks at the top line there, more than 80% of the hospitalization actually occurred in well-nourished term infants with no risk factors. And it's not really a surprise because that makes up the bulk of our babies are going to be well big babies if our preterm babies are only making up sort of 15%. So both strategies are safe and highly effective. The issue really just now becomes the cost and the access. If we're going to have Tdap and RSV, preferably space them 2 weeks apart, but if they do need to be given at the same time, preferably in two different sites, so two different arms, so we can co-administer them. And there is currently a technical working group making recommendations. So the different options that we've got for monoclonal antibody use, given the price, we need to think about it. So do we do it as a primary strategy for all infants? And there have been one or two countries who've implemented that, and they have had very good success, but obviously it's a very expensive option. Is it an alternative completely to maternal vaccination? One could do that, then just not vaccinate mum at all. Or is it a selective and adjunct or an adjunct option? Infants where the moms were not vaccinated. So your mom who comes in, she hasn't been vaccinated because she didn't maybe book or whatever it is, and give it to that baby. Infants whose mothers did not receive it timeously, so they delivered very quickly. And then the high risk infants. So even if mum was vaccinated, give it to those who are severely premature with heart disease, chronic lung disease, HIV, or babies who are HIV exposed or HIV positive, inborn errors of immunity, neurological, neuromuscular disease, and from age 6 to 24 months at the beginning and during the RSV season. So to do it in that early part of the year, and that maybe will also just try and reduce the number of people requiring it. So really, I've reached kind of the end. I don't know if I was maybe too fast. I never know if I talk too quickly, but I
No.
think we can chat then a little bit about it. But I think these are the bits that have to now be decided by the working group. So there are a number of people on it. And I think we've got a position paper that is going to come at some point. So I got to put my 2 cents worth in there. And we're waiting to see if that'll be published. But it's now up for discussion.
Yeah.
Amy, that's wonderful. Can I just run through one or two questions? Can you see the questions over there? For example, Leon Nell
Let me see. I need
under
to open.
Q&A.
I'm looking. Yeah.
It says, I'm going to read it out because obviously not everybody. There's hundreds of people over here that are logged on, but for their benefit, says Leon Nell, you've got it there. It's ill-advised to use the COVID vax now with an efficacy rate of 0.88% of preventing infection and massive reports of vax injury. Also, no safety data in pregnancy. Could you comment on that, please, Amy?
Yeah, I think that for now it isn't indicated because there's no surge and there's no COVID problem at the moment. But I think at the time when we were giving it there, we felt that there was enough information to give it, and obviously the the mothers suffered more so than your general population. They always do in the third trimester. So I think at the time it was the correct thing to do. I do think that we've got a lot more reports now, as you mentioned, about vaccine injury and everything. And so I think there will need to be probably a large review of all the data, and especially good data, because obviously, there's lots of grey literature out there and sort of case reports, but it needs to be a large review to say if there is another surge, how are we going to manage it? But for now, the guidelines do remain that if there's a surge, we should again vaccinate. But I do hear the concerns, and I don't think that they are unreasonable concerns. And I think especially in some of the young adults and young men where there's been cardiac concerns, and as well as the embolic phenomena, which is always a worry in pregnant women. I don't think it's without justification for people to be concerned.
Is there any these last question, Leon? Is there any safety data relative to the use of COVID vaccine in pregnancy?
Is
Is it
there
safe
any?
in pregnancy? In
Is it
pregnancy,
safe in pregnancy?
COVID
Yeah,
vaccine.
I don't think that from what I recall, I haven't looked at it for a while, but from what I recall, I don't think there was anything which made it less safe in pregnancy, and certainly I don't think it caused a problem. The general outcomes we look at, things like preterm labor, etc., those are always worsened by anyone with a viral illness. So you've got to tease out the two that if they've catch a viral illness, they're far more likely to land up being a preterm labor, and certainly those who got COVID badly, we know that they died. It was horrendous. And we had a number of deaths ourselves at Rahima. So I think certainly I felt that it was worth the risk at the time of rather taking the vaccine than not. But I'd have to go and
Okay.
look for the data again.
So as far as you recall, risk versus benefit was
It
favorable.
it was favorable, yeah.
Okay, one more question over here. How do we increase the uptake of vaccination in private practice?
I
Do you
think
have
that
any ideas on that?
yeah, so whenever we have one of these like big talk shops about what are we going to do, my biggest concern is always private practice. And like I said, I think the part of the problem is the way the care is arranged, and it sort of lands up being on the individual practitioner to work out their own plan with your either your local GP or within your hospital group. If you're lucky enough to work in a big enough hospital group, I know some of them have a GP who works at the hospital who can then provide that linkage within, and will give the vaccines and that kind of thing. I also think it's really important that when you put together your stationery that you're going to be using, that you've got some sort of to be asking and offering at different points, and then probably to provide the information to patients beforehand so that they can ask, because you've only got so long in an appointment to sit and answer all the questions and say all the different things that are required. And so I would suggest that you create for yourself a pack of information so that patients can read it beforehand, and then they can come in and you can run through it a little bit more efficiently and answer their questions, so that you can try and get the uptake. And then you need to make it easy enough that also that your pharmacy has it available. A phanmacy must have it available. I would hope by now that Tdap is available everywhere, and that you've got there's lots of literature out there which is patient friendly, which can be provided, and I do think it should go out. One of the things that's quite nice that they've done from Sanofi's side is there's a thing called taxi Wi-Fi. I don't know if you're aware of it, but if you get
I know I've
into
never been in a taxi. I've told it's dangerous.
so if you get into a taxi next time, those that are enabled, if you watch a video, you get airtime. So like Checkers and various other big brands, and then including places like Sanofi and then the Department of Health, actually are running these ads. And so the more ads you watch, the more little taxi bucks you get, or whatever they call it. And that's how people are able to then get more airtime. And so that is a really good way of actually getting through to people and trying to get the information through in small little bites. Within the private sector, those who maybe are not accessing that kind of thing, I do think the big companies are trying to produce patient-friendly information, and I think as a healthcare practitioner, you should try and make sure that make sure that your patients get that information. Give them the links. Most of them are online in some sort of way, so that they're also reading balanced information and not just anything that cruises past them on their phone.
Yeah.
There's a
Well,
lot of
Amy,
dodgy
I don't
stuff.
think it's that difficult. I mean, if we don't have time, I tell you where I spend most time in my practice, and I do lots of obstetrics, 20 deliveries a month, is with my receptionist. And right outside the receptionist's office here is a big sign saying SASO guidelines suggest the following vaccinations during pregnancy. Now, I must admit, I don't have rabies there because I don't want to start talking about rabies vaccination. But the
No, no,
others are
no.
all there. The others are all, influenza and Tdap, and RSV is all there. And if they're going to spend hours or minutes talking to the receptionist, they're going to see this thing and they're going to ask about it. And then they can take their pack and read that at their leisure. So it doesn't take any more time than talking about pap smears, for example. So it can be
Yeah.
done. if you just think about it.
I think it can be done, but it just obviously, I think we are asking people to talk about a lot of different things. And so that's why I suggest I don't think anyone can remember everything off the top of their head that they're supposed to mention to their patient. And so that's why I suggest that, you have whichever system you're using, if you're paper-based or you're electronic-based, that you've got yourself reminders at the different visits that you're going to have, to prompt yourself to talk to the patient, or at least to make sure that that information is provided and that you try and remove the barriers to actually getting the vaccine. Most people are not going to be giving vaccines in their room, so you need to then make sure that it's easily available for the patient.
Yeah.
I think the difficulty comes up now of the patient, if with the medical aids, is if it comes out of like a medical savings account, and now the patient's trying to decide, are they going to do NIPT, if they're going to do a vaccine, are they going to do more bloods? And the financial crunch, unfortunately, I think is a problem. And if the patient's going to try to decide like which thing is going to be, best, or they're rather going to go do the 4D ultrasound down the road to say hi to the baby. Bit of a tricky one.
Yeah.
No,
Well,
so I want to check, Pete, sorry, so I just want to check with you guys then. So in terms of the medical aids, are they supporting the RSV vaccine at all, or
which do they cover?
yeah, is it really dependent
I
on?
couldn't tell you which one they cover. The last time when I was at the launch, the lady I was sitting next to said she was busy in talks with Discovery. So I don't know that they cover, if they're covering it as a, like, what's it, a prescribed minimum benefit, or whatever you call it, that it
PMD
doesn't come out of your
or the
PMD, or that it
PMD.
doesn't come out of your medical savings. Because I mean, I don't know about you, but where are we? March. My medical savings is just about done for the year. So at 6,400 for the baby, or 3,400 for the actual vaccine for mom, it's a lot of money. And I'm not sure how patients are going to, yeah, feel about it, if they're going to like weigh up, will it be my kid, or can I take the chance of not taking it? It's tricky. I don't know, in your
Yeah.
practice, what do your patients say?
Yeah, it is a big issue, and I don't get involved in medical aids. I say you must contact your medical aid and see. What I can provide you is Sanofi's given me like a pack of
Yes.
all of those things, the Tdap and whatever they call their one, Abrevio, and
Mm.
I say this is highly recommended. It's in aligned with SASO guidelines, and we recommend it. So you'd have to speak to your because there's so many bands. I mean, Discovery's got so
Yeah.
many bands. They've got more bands than I don't know. So they have to discover which is covered and which is not covered, and then to take it from there. And also your relative risk, your cost versus risk benefit, and the risk versus benefit, all those things must be decided by the patient herself.
But Pete,
Yeah.
it's an interesting thing, and I mean, it's an interesting thing. I mean, you think about one ICU admission, that's going to be at least, I mean, a month or two in ICU is going to be nearly R1 million. So, and you're preventing 35 to prevent one case. I mean, it's starting to make financial sense quite soon. Just from economic point of view. So, really nice.
I certainly think so. I think that's
Yeah,
what those are the numbers that are being
yeah,
presented.
yeah. So,
Well, it's absolutely true, Steve, what you say. I mean, I get every vaccination that's going around. I've even been vaccinated against herpes and shingles. So I can tell you this, when I got my shingles, it was very attenuated. And I said, thank heavens, I got my shingles vaccination. And where do you get shingles, Steve? In a,
chickenpox, Pete. Get it
in
on
a sheep?
your face, or yeah, where you got yours,
No,
Pete.
no, you get
If you don't
shingles
want
in
to
a
mention it, Pete.
no, you get shingles in the shingles bar. So if you ever go to a shingles bar, you're bound to get it. Okay.
Okay. Anyway, let's not talk about that. No, that's but look, I mean, it's a severe infection, and I think we don't think about it enough. I think the pediatricians, on a personal level, have highlighted this very much to me, and I think when they see the really sick patients, it's just quite bad. So, you don't think about it until you actually get exposed to a few sick babies with RSV, and you're going to those ICUs, neonatal ICUs or pediatric ICUs, I would say, especially in winter. It's bad. The babies are really sick, and they don't do well. So it's something we really need to think about, and maybe every now and then one of the obstetricians should pop into the ICU and see how these babies are doing, and you'll think carefully about how you counsel your patients as well. It's a very important
Yeah.
condition.
Yeah, no, look, I think it's a frustration for pediatricians that they kind of rely on, the
Obstetric.
obstetrician to try and protect the baby for them. So it really is something we need to work together.
Yep.
And you've got a captive audience in the pregnant women to vaccinate, whereas once the baby's born, it can also fall down the radar as well, and especially it's a lot more expensive. I mean, 6,000 rands difficult being new parents often. So I think that's a difficult one too.
Yeah, So I think for now, I think cost effectively, I think it's better to vaccinate mum, and also then obviously like she gets the benefit, which I think is important, and is not going to get sick herself. And I think that is obviously very useful.
Well, thank you, Amy. I'm going to ask Steve to formally thank you, and
Oh,
then Steve, if you wouldn't mind formally thanking Amy Wise.
Yeah, thanks very much, Amy. It's been wonderful to have you on. It's such a great talk and really so clearly demonstrated the benefit of the RSV. I think it's also we've also had a great number of people on, and I think you've brought to our attention something that should not be voluntary in terms of how we counsel patients. I think they should all be aware of this, and those who can afford it, I mean, it makes sense that they should be getting it. So thanks so much for the time to prepare and to be with us tonight. We really appreciate it, and we'll definitely have you back. Um, and I mean, there are a lot of other vaccines to talk about in detail as well. So I mean, maybe we should look at doing that quite soon again, Pete. So thanks so
Yeah,
much.
Steve, absolutely right. And it's updated. So Amy has taken a lot of time and trouble to do this. Just to remind people that this is all voluntary. We don't have, what's it when they give you money? Not kickbacks, honorariums. That's the
oh,
word.
we're good for kickbacks. I'm okay for
You're all in
kickbacks.
favor of kickbacks, as we are.
We can.
Yeah.
And for those people that will wish to further engage with Amy, she is going to be at SASOG. Just to remind you that SASOG is in August. It's in Cape Town this year, and it's the beginning of August at the Century City venue. So Amy is presenting. What are you presenting, Amy? Just remind me. You told me earlier on.
On rhesus disease.
Oh,
So
Rita.
yeah, my registrar's just finished looking at all the data from SANBIS covering 8 of the 9 provinces, looking at the amount of antibodies. So yeah, I'll have the results.
So that's something to look forward to. There's nothing that she hasn't put her finger in the pie of. And Amy, thank you once again. Steve, thank you very much indeed. We look forward to just remind you that next Thursday is Maundy Thursday. So because of the Easter long weekend, we won't be presenting, but we look forward to seeing you same time, same place, 2 weeks hence. Thanks very much indeed also to Chris.
Thank you very much. Thank you.
Yep. Thanks,
Okay.
everyone. Have a good evening.
Bye.
Okay,
Safe
bye.
home. Safe
Bye.
home, Steve.
Bye.